Good afternoon, I'm Mairead Painter, the State Long-Term Care Ombudsman in Connecticut. Today is April 9th, and we're joining you a different night of the week, different time. We have Barbara Cass with us, the branch chief from the Department of Public Health, here to talk about visitation. We talked earlier today with our long-term care communities and felt it was important to ensure that the same information was available to residents and family members. I want to thank everybody for submitting questions. We did take all of the questions and tried to bring them together so that individuals had an opportunity to have their question answered without asking a lot of the same questions at once. So Barbara, thank you so much for joining us.
Good evening, everyone. It's my pleasure to be here.
Before we get started, there are some slides from earlier today that we'd like to share, and we're just going to go through them very briefly as an overview, and we'll make sure that they're available to you online and that you have access to them. I know it's stuff that we've gone over many times before, and so I don't want to spend as much time on it. We know that it's really important that individual questions get answered. So Dan, if you could pull up those slides. All right, great, thank you. So the first slide, we're going to talk about general residence rights. So this is what has always been in place since 1987, the Nursing Home Reform Act. Residence rights promote and protect the rights of each resident. Sorry, the Reform Act promotes and protects the rights of each resident. And there's a strong emphasis on individual dignity and self-determination. We know that this did not change during the pandemic, but there were a lot of instances where there had to be accommodations made because of the infection controls measures that were in place. We know that residents, when choosing to make a long-term care community their home, they don't lose any of their rights as a member of our community at large. But during this situation, there were parameters that had to be put in place because of those infection control measures that really did impact residents' rights in a different way than they did for us as a larger community because of the amount of people living in a small space together and the risks associated with that. So these are just general rights. And I wanted to make sure that we paid close attention to, we all have the expectation that residents are treated in a way that is person-centered and have an opportunity to participate in their plans of care, which should be person-centered plans of care. And they have an opportunity to invite people that are important to them. When attending a plan of care meeting, that is not considered a visit. All right, Dan. This is a portion of the revised guidance that we did review with the long-term care communities today, focusing on the need to have indoor visitation available at all times for all residents, except for in a few circumstances. And CDC and CMS, so the Centers for Disease Control and the Centers for Medicare and Medicaid, have put out very clear guidance, as well as our own Department of Public Health that has an algorithm to decide when it is appropriate to have indoor visitation and what residents can have access to that related to if there's any COVID-19 cases within the home. We know that compassionate care visits are required at all times, even if there are positive cases in the home, but that's something that you would discuss one-on-one with the nursing home. Our team members can also help you advocate for the need to have a compassionate care visit. And we talked today with them about the fact that they really need to look at why the individual is saying that they would like a compassionate care visit, what need it meets, and that it's not a decision just by the physician or the APRN. We talked about the fact that you always have access to see your long-term care ombudsman within the nursing home, and that with resident permission, we have the right to ask to see their medical, social, and administrative records. Required visitation. So facilities under the new guidance, it outlines they can't restrict visitation unless there's a reasonable clinical or safety cause. And it has to be consistent with the federal resident right regulations. Okay, Dan, if you want to go to the next slide. And this is sort of a drill down of those regulations, that they must have a written policy that explains to all of you what to expect and when to expect it. In that written policy, I would expect to see an outline of any parameters by which that they would pause visitation and what type of visitation would be paused. Are they closing indoor visitation, outdoor visitation, and why? We did focus on the fact that staffing, I'm saying that we don't have staff on weekends or evenings to provide visits or to clean the rooms afterwards, that wouldn't meet the standard for visitation and for the residents' rights. Also, that they must inform each resident or their representative of their visitation rights as related to this policy and their individual policies and procedures within the home. So you can ask for a copy of that. It should be a detailed copy so that you understand if and when visitation is paused, why that's happening. All right, Dan, and now you can jump over to Barbara's.
So I just want to piggyback onto some of your remarks, Mairead.
Sure.
We are at DPH delighted that we can indicate that visitation, indoor visitation, has now been opened, that the doors to the nursing home or the gates to the nursing home are open and we can reunite families. However, I think it's important to note, and I will be very cathartic here, last September, when we received the S&C or the QSO memo indicating that indoor visitation would be open, I think all of us paused for a very short second, and there was a little bit of fear and trepidation for all of us. But we knew how important it was. We had to reunite families. We had to reunite residents with their loved ones, with their friends, with the hairdresser. The hairdresser is an important part of many people's lives, myself included. So we've been doing lots and lots of work. There's been lots of training, lots of counseling to nursing homes. And we're now starting to think that we may need to pivot. Nursing homes do need to be open to visitation, certainly following the CMS guidance and the QSO memo. So when we got the revised guidance that indicated indoor visitation could start, that was very exciting for all of us. So the next couple of slides are going to review the highlights, things that probably all of you already know. And the first slide is really the most important slide with visitation. It's the core principles of the COVID-19 infection prevention program. I'm sure each of us on this call can state all of these things with our eyes closed. All of those core principles will continue to be followed with visitation. So when you are going to visit your loved one or your friend in a nursing home, you can't expect to be screened still. Screening is critical. Temperature taking will still occur, and questions will still be asked. Hand hygiene, I don't think any of us can wash our hands enough. That will still be continuing. Source control or face coverings, and wearing the face covering appropriate. How many times have any of us seen the face covering and it's covering a mouth, but not a nose? So it's critically important that it cover both sources, which are the nose and the mouth. Social distancing. We've heard lots of things about social distancing. CDC has suggested that is 3 feet enough, but for the purposes of indoor visitation, we will continue with the social distancing of 6 feet between persons. There should be signage throughout the facility, reminding people about masks, reminding people about hand hygiene. Cleaning and disinfecting, that will still occur. We want to have all these control measures in place to keep all of our loved ones safe. PPE will continue, and effective cohorting of residents has been, I think, one of the most important things that we've learned throughout the entire pandemic. And because we are all doing a good job with this, we're continuing to see a low incidence in our state. And then the resident and staff testing, that was written into an executive order, and weekly testing is continuing. I will be candid and tell you that I'm not sure how much longer weekly testing will continue. Now that we are seeing high vaccination rates in the state, not only with our residents, but we're seeing fairly high vaccination rates with healthcare employees. Would we like to see it higher? Absolutely. But we are not a state that's going to mandate the vaccine. We are going to be starting a little more messaging and the importance of vaccination. But as all of these processes continue, they will continue to contribute to our control measures. So next slide, please, Dan. So compassionate care visits. I think this is one of the most confusing things for everyone. What constitutes a compassionate care visit? Early on in the pandemic, when we were talking about visitation and the importance of compassionate care visit, I think most states were thinking about end-of-life situations, that if an individual were in a hospice situation or if they were getting ready to pass, then that is what constituted an end-of-life situation or a compassionate care visit. In June of last year, CMS released a FAQ, a frequently asked questions document, which was game-changing, I think, for all of us. And it really expanded the definition of compassionate care. It really is a resident-centered assessment. It's unique, it's independent to that specific resident. And while we've done lots of education with providers, we still continue to see questions with this. So we will continue to do education, and we will continue to monitor that compassionate care visits are being offered, and they should be offered at all times. If the facility is in the middle of an outbreak, or if there's high county positivity, compassionate care visits should and will continue. They should not be suspended. But there are a few rules that do follow compassionate care visits, and it's those core principles of infection control. Social distancing. The newest change is if a resident is fully vaccinated, there can be touching now. And I know for many of us that was very important. Important to note, though, that when you do touch, you do need to practice good hand hygiene, and you should continue to be practicing good hand hygiene when you're wearing your mask. Residents that are on transmission-based precautions, and that would be a person who is either in an exposed unit or a positive unit, could have a compassionate care visit. And again, physical distancing or social distancing is still something that should be practiced with a compassionate care visit. Dan, if you could just change the next slide, please. Outdoor visitation. Outdoor visitation should be occurring at all times. There are very few situations where outdoor visitation would be suspended. And you'll note on the bottom of this slide, it would only be in the presence of a very large scale outbreak in the building, or if the facility is having significant resource issues, either with access to PPE or significant issues with staffing, and all efforts have been unsuccessful. With outdoor visitation, it still occurs if the facility is doing outbreak testing because there was a recent outbreak. So again, just to reinforce, outdoor visitation continues to occur even if there's an outbreak in the building. Dan, next slide, please. Now, indoor visitation, that's the newest revision to the CMS guidance. It should be allowed at all times, except for these provisions that you will note on the screen. And again, if the nursing home's COVID-19 county positivity rate is greater than 10% and 70% of the residents in the facility are fully vaccinated. Indoor visitation should not be occurring on a unit where, unless it's a compassionate care visit, on a unit where there are residents with confirmed COVID-19 infections. And vaccination status does not matter in this situation. And indoor visitation will not occur for residents that are in quarantine. And again, vaccination status does not change any of the decision-making here, and until they have met the criteria for release from quarantine. So when they are transferred off that unit, or if the unit is meeting the definition of release from quarantine. So when facilities are offering indoor visitation, they should give consideration to the number of visitors per resident at the same time. And the total number of visitors that are in the facility at the same time. Visits for residents who share a room. So if your loved one or friend is residing or sharing a room, if possible, that visit should occur in a common area, but there will be situations where a resident cannot be removed from the room. So the facility should make some accommodations to that, and they should enable the in-room resident room visitation at the same time adhering to the core principles of infection prevention. At all times, they need to maintain distancing. And then if the resident is fully vaccinated, again, they can have close contact with their visitor while wearing a face mask and hand hygiene before and after contact. So Dan, if you could proceed to the next slide. So let's talk a little bit about if there's a new onset of COVID in the facility with a resident or a staff. And as you may recall from previous Facebook Lives that Mairead has done, one case constitutes an outbreak, and one case could either be with residents or staff. So when that case has been identified, the facility should immediately begin outbreak testing. At that point, they should suspend all indoor visitation. And that's critical. The outdoor visitation will continue to occur. But the indoor visitation is suspended until at least one round of facility-wide testing. And facility-wide testing includes employees and residents. And we have, while the guidance does not indicate a time frame, we have provided a time frame of we expect the results to be turned around in 48 hours. If there's a problem with the lab, then the facility should do their antigen test. Visitation can resume based on criteria that's been developed. So if the first round of outbreak testing reveals that there are no additional COVID-19 cases, then the indoor visitation is suspended in that affected area. So if that one positive case was identified in Unit A, no further outbreaks or no other cases are identified in Unit B and C, then indoor visitation is suspended only on Unit A. Unit B and Unit C can continue and resume visitation. If the first round of outbreak testing reveals one or more additional COVID-19 cases in other areas of the facility, then the facility should suspend visitation on those affected units. And that suspension will occur until the facility meets the criteria to discontinue outbreak testing. So that's 14 days with no new cases. And if subsequent rounds of outbreak testing continue to identify one or more additional cases, then facilities should suspend visitation again until the facility meets the criteria to discontinue outbreak testing. Next slide, please. And then these are the regulations that are already existing in the Code of Federal Regulations. Mairead did a very nice job of doing an overview of these regulations. They do focus on resident rights, and residents do have a right to visitation. The facility must provide immediate access to residents and family members. The facility should have policies and procedures regarding the visitation rights, and then again, including those that are clinically necessary, and the policies and procedures should include reasonable restrictions or limitations or safety restrictions that may impact visitation in the building. And I think we have one more slide, Dan.
Nope, I think that actually is the last one.
Okay.
So we have the algorithm and those types of PowerPoints available online already. And so we will include these slides with them. We know that the algorithm that the Department of Public Health has put together has been incredibly helpful as we've been advocating for visits. Now, we have an opportunity to answer some questions. Barbara, I know we had sent some questions over that people sent us during the week. We also are getting a few online. And why don't we jump right into it just so we have an opportunity to get to as many as possible. The first question is, there are extreme inconsistencies in the interpretation of the CMS guidance by facilities across the state. Some choose to interpret the guidance extremely limiting. Some only have 30 minutes for a visit. And others have really expansive visits where people can come spend time with their loved ones in a very person-centered way, meeting the residents' needs and allowing visitors at all times, as long as they're calling, they're saying we want to visit, and they're allowing that. How will DPH monitor or enforce to the fullest extent the guidelines that demonstrate a person-centered approach and require that facilities meet the residents' needs?
Okay. So we've identified that there is an inconsistent approach. We've had lots of conversation with the Ombudsman's office about facilities that are doing an amazing job with visitation, and then other facilities that may have some challenges. So we have done some follow-up. There are inconsistent interpretations of the visitation guidance. And lots of the questions that we've been trying to problem solve are related to the outbreaks. Last weekend, I was working with a facility who had an outbreak in the building, and the employee, I want to get the dates right, the employee tested positive for COVID on 3/25, but had not been in the building since 3/18. So the facility wasn't clear about when the clock started. Did it start from the test date, or did it start from the time the facility, from the time the staff person had been in the facility? It did go back to the earlier time frame, but the facility had exercised the second date. So we're trying to help facilities problem solve when there are those inconsistencies. So to respond to how will DPH monitor, we are monitoring that through complaints that we're receiving. DPH has started surveys. Our certification surveys have started up. They are not going or have been initiated with the same rigor that we usually do, but we have started to conduct those activities again. Last year around this time, you may recall that CMS had suspended all survey activities and complaint activities in nursing homes unless they rose to the level of immediate jeopardy. So we have resumed our activities. You will see us more, again, not with the same rigor, but we intend to monitor visitation, their policies and procedures, treatment planning. What kind of treatment planning has been done for residents who are not involved in active visitation or who haven't been receiving visitors? It's very important that there be a psychosocial care plan in place. So we are looking at all of that.
Great, thank you. And the next question is kind of a follow-up to that. How are facilities held accountable to meet those needs?
So during the course of our activities, if we should identify that there is non-compliance, a violation letter and a deficiency statement are issued to the facility. The first tier of enforcement is that, the violation letter and deficiency statement, and we request a plan of correction. So what is the facility going to do to mitigate risk of this issue happening again? So it is very important for DPH that families become reunited with their loved ones who are residing in the nursing home. So violation letters, plans of correction, and we will be monitoring this on all of our activities now.
Okay, and C kind of, I think you've already answered C, which said, how will DPH respond to complaints? And you said you'll be going in on complaints.
Yes.
For visits being denied. And are these rights being denied? Are they, when they're being violated, that you guys will be going in? I know our office has been communicating a great deal with the Department of Public Health when individuals bring it to our attention. We are communicating that directly to DPH. And I know last week we filed complaints regarding visitation, I think on Wednesday, and then we heard that DPH was out on Thursday to follow up. So there has been quite a level of turnaround when there's issues and concerns related to residents not having access. So thank you for that, Barbara. How much advance notice is required to be given to visit a nursing home? Can they require that our visitors give 24-hour notice before a visit is granted?
So I think that's going to be predicated on each individual situation. I think there needs to be some level of reasonableness. The CMS guidance does indicate that facilities need to monitor visitation. And they need to monitor visitation to ensure that the core principles of infection control are being followed. So I don't know if 24 hours is unreasonable. Giving a blanket time frame, I don't think we're prepared to do that. However, if there is a compassionate care visit, that's a very different situation. And if there's a compassionate care situation, I think there needs to be at least immediate consideration to the request, and it needs to be assessed to see if it meets the requirement of a compassionate care visit, and that should be a very quick turnaround.
And one of the
Compassionate care visits are usually an emergency. Sorry, Mairead.
No, that's okay. And I agree. That's the compassionate care visits do need that focus. One of the concerns that we've heard is related to, I was able to get the afternoon off of work. I called the facility and said, I have some time, I'd like to stop and see my loved one. And they'll say, we're not doing visitation this afternoon. And so that's where we've seen a challenge, and we're really asking homes to ensure the fact they need to have access if it's not because there's too many people, right? So if a lot of other people are visiting at that time, that to me might be a reasonable reason to say, we already had other people scheduled. We have an opening later this afternoon, or maybe you can come at 7 this evening, because people had already scheduled these periods of time. Where we would have a concern is if they were saying it's Wednesday afternoon and we don't allow visits on Wednesday afternoon. That's where there's been more of the challenges raised.
And we would share that concern at DPH. I think there needs to be reasonableness for all of us as we reintegrate families with residents. But for a facility to say we don't do visits on Wednesday or Sunday because we don't, that's not reasonable. Absolutely not reasonable. So those are situations that we would suggest you reach out to the Ombudsman's office when those are occurring. And again, Mairead and her team, we communicate a great deal with them, so we can intervene as well.
Thank you. Can you describe circumstances under which an in-room visitation would be denied to a resident who wants to visit in their semi-private room? And is there any length of time of a visit for a resident in a semi-private room with a roommate that doesn't have any visitors that day?
So I think you'll remember, or you'll note that in one of the slides, we would prefer, the guidance indicates that to the extent possible, first, the preferred visitation is an outdoor visitation. That's the safest visitation. But we know that we live in New England, and there are lots of elements that interfere with that. So indoor visitation, we want that to occur. To the extent possible, when there are residents that share a room, it should be in a common area. There may be unique situations where an in-room visit, when the room is being shared, if the resident if their medical condition doesn't permit another visitor in the room or would put them at risk, that would be a consideration. There may be behavioral issues that would cause something like that to not be the best plan of care for the roommate who was not getting the visit. But I think that if that's the only way a visit can be offered, so for example, if a resident cannot get out of bed, then an in-room visit, to the extent possible, that accommodation needs to be made.
Thank you. So this next question is the one that we've currently been hearing the most about. Staff shortages are a regular reason given as to why visits can't happen. Shortages will not be fixed in the short term, and in the past, family members have supplemented the shortage of help. Is staffing shortages a reason to not have visits, especially in the evenings and on weekends? Because that's something we are hearing. There's no one to clean the rooms afterwards. They can't support visitation at those times.
So again, I think I'm going to go back to the concept of reasonableness. I think for a family member who they only can visit in the evening, or they only have the availability or ability to visit on the weekend, then it's incumbent upon the nursing home to make that accommodation. They need to be planful. Again, it does take more resources to have indoor visitation, but indoor visitation certainly is something that CMS and DPH are embracing, supporting, reinforcing that they must happen. So I guess the short answer is staffing shortages is not an adequate reason unless there is something that's very unique to that day, that they had 3 people scheduled and 3 people suddenly got sick and they weren't able to support the monitoring. So there may be unique situations that may be a reason not to offer visitation, but for staffing shortages to be the overarching reason why weekend visits, evening visits cannot occur, that would not be acceptable. Again, facilities have to be planful.
And we know there's going to be a lot of people that want to visit, especially with these nice weekends coming.
Mm-hmm.
Okay, if that is the reason that's given, will the facility be fined for not meeting our needs, or for visits, or for low staffing? Low staffing continues to come up just in the way of care as well. And is that a reason for that a building might be fined?
So there are certain situations when DPH can impose a civil penalty. That could definitely be a reason that a facility would receive a violation letter or a deficiency letter and need to submit a plan of correction. If there was a negative outcome to a patient because of that lack of visitation, and there could be, it could be an emotional negative outcome, then there could be a civil penalty assigned. But at the very least, it could be a violation or a deficiency. And again, they have to provide a plan of correction, what they're going to do to mitigate recurrence.
What is the requirement to ensure that dehydration, weight loss, and potentially death do not occur or are prevented when a loved one is not allowed regular access?
So the requirement is that no resident should be experiencing dehydration, weight loss, and or potential death. That is absolutely should not be occurring unless there was a medical reason that is interfering with a person's ability to either hydrate, or if a facility or a family member, pardon me, if a family member has made a declaration that their loved one does not want artificial nutrition or IVs. Weight loss should not be occurring. The pandemic, while we know socially and mentally there were lots of losses, and weight loss is a manifestation of sadness, we expect, though, the facility to be monitoring that. So if someone has had a weight loss, the facility should be taking action for that resident to have enhanced nutritional needs. They should have a dietary consult. They should be on intake and output. The facility should monitor their nutritional status and be more vigilant about that. So in the cases where there is a potential dehydration, weight loss, or a significant change, the survey is going to pick up that significant change through the MDS. We will review the records, and if the facility did not respond appropriately, then we will issue a violation. And in those cases, there's likely going to be a citation with a civil penalty.
Thank you. So the next two we can kind of, I think, maybe even combine a bit. You discussed how DPH is ensuring that residents have access to people who support their needs above and beyond, right? That it should be a person-centered care. We talked a little bit about compassionate care visits. And something that comes up to us regularly is the challenge that we found to have a designated caregiver related to essential support person or essential caregiver. We talk a little bit about how DPH is able to ensure that residents have access to individuals like that in their life when it really makes the difference between them finding success in their day and struggling. So,
Mairead did share a copy of the questions as well, so I keep looking down in my paper. So I think the question is about the essential caregiver role. And we've had lots of discussion at DPH about the essential support person. Actually, that's where we landed at the very end. And the department is supportive of that program, but we see that that program aligns and ties in very nicely with the compassionate care program, that individual is similar to, if not the same person as the compassionate care person and the essential support person. So through that resident individualized assessment, that should be identified. So if family members, for example, a resident who is not eating well, and every day their husband or their wife come in to feed them, in many cases, that person would be assigned or designated the essential support person. But it also aligns beautifully with the compassionate care visit. So that person should be given access as is required by the assessed need of that specific individual. There was a two-part question there.
it was, and the questions as to why it wasn't supported as a bill to move forward to have that policy in place for the essential support person. When it came up, there wasn't any comment.
So we had been working collaboratively with the Ombudsman's office, the two trade associations, and so we do support the bill. Did we not comment on it? I can't, there were so many different iterations.
Yeah.
So I know today it's in our long-term care bill because we did a fiscal note that's moving forward. So we do support the bill and we support that provision of the bill. So I think last at like 2 o'clock, I think the substitute language, it was still moving forward. Is that your recollection, Mairead?
I've not been off web meetings all day, so I
Oh.
haven't seen language yet, but I will certainly be looking at that, and I'm sure other people will let us know. But we're very supportive of it, and we have had lots of conversation between the Department of Public Health, the trade associations, and like anything, we don't always land in exactly the same spot. But I think the one thing that we all acknowledge is there is a need, and that having that individualized need met. There are some residents that without that essential support person don't find success in their day. There are other residents that are able to have their day and move forward, but it's crucial for some individuals. We want to make sure that that's honored. When can volunteers go back in and support residents and potentially support visitation?
So volunteers are treated as indoor visitors, not indoor visitors. They are treated as visitors. So when the building is open for indoor visitation, volunteers can continue to start their programming, or I'm a nursing home volunteer myself. So I'm waiting for my call back to service. I've not gotten it yet, but waiting. So when it's open for indoor visitation, the volunteers can be in the building, as well as the hairdresser.
The hairdresser. So I would say if you are a volunteer and volunteered in the past, to reach out and maybe reconnect with the home you were volunteering at and see if there's the opportunity to re-engage with them. It has been the experience of many of us that complaints are not always addressed in a timely way, and visitation may not seem like a life-threatening or urgent, but for some of us it is everything right now. How can we count on DPH to help us?
So for the first year of the pandemic, we were focused on, and I don't want to suggest that it was our only focus, but the focus really was infection control. We wanted and needed assurances that good infection control principles were in place as a control measure to mitigate risk, to control risk of transmission. Visitation has always been important to us. I think I would be remiss if I didn't acknowledge that this has been a very difficult year for families and residents. Not being with your loved ones has been hard. It is a priority for us. As our teams are out there conducting certification activities, they are looking at the visitation policies and procedures, ensuring that indoor visitation is being honored when it's appropriate, and at all times that outdoor visitation is happening and compassionate care visits are occurring. I mentioned that last year around this time, CMS had suspended any complaint investigations or any survey activities from occurring, and that was the critical focus for us. It has been hard. It has. I know since last year I've spoke to many of you, either on the phone or through emails, and I know that this has been painful, but I think it's a time that we can now celebrate, that we can reunite, and we just have to continue to reinforce that messaging to nursing homes and reinforce that they're doing it right.
Thank you. How is DPH going to respond to visitation complaints and not just ask the facility who says everything is fine?
So if we receive a written complaint or a verbal complaint, we are a state that does take verbal complaints, and we also investigate anonymous complaints. It will be entered into our system. It'll be assigned a triage, and we are objective data collectors. We do not have any preconceived notions that the facility's right, the family's right. We are objective data collectors. So for example, a visitation allegation, if the facility is not honoring visitation, we are going to explore, talk with the family, talk with the facility, look at the policies and procedures. We're going to want to see that active indoor visitation, if it's appropriate, is happening, and also that outdoor visitation is happening and that compassionate care visits are available.
And we've
So,
been focusing on it being meaningful. When we're working with buildings, there were concerns about people kind of being whisked away in short visits, or people wanting to sit outside for a period of time, maybe an hour or two with a family member who brought their own chair and sit apart and talk, and really having that honored in a meaningful way. If there isn't any other reason why it shouldn't be happening, that should be supported.
yes, we would agree.
So in some cases, individuals have felt they've had no, or they haven't had any response from DPH. What is the specific policy regarding response time to complaints for residents and family members?
Okay. Why don't I send you Mairead Chapter 5 of the State Operations Manual? And it's kind of dry reading, but that does direct the complaint process. It does indicate the timeframes. So when a complaint comes into DPH, you should expect an acknowledgement letter after we've reviewed and entered your complaint. So if you have sent in a written complaint to DPH and have not received an acknowledgement letter, please send me an email and I will follow up on it. So all of those parameters, the acknowledgement letter, the time from receipt of the complaint till the time we get out to investigate the complaint, is all prescribed in Chapter 5 of the State Operations Manual. However, I just want to underscore that the past year, since March 4th of last year, all of those activities have been suspended. So we are resuming them. So Chapter 5 is alive and well again.
And we have started to hear that. We've started to hear that people have been out on complaints. We've started to get feedback about that. And I think there was a level, because normally people's experience is that when they have a complaint, someone comes out and investigates it. The challenge of this year with not having that response has been very frustrating for residents and family members, which I totally understand, because they were feeling very stuck.
So if there's a family member or someone out there who has submitted a complaint, has not received the acknowledgement letter, even if we were not going to get out there right away, we should have sent an acknowledgement letter. So I am happy to follow up on that. Okay. And the clock now is starting. So if you have sent in a complaint, I would say be patient with us. I will tell you anecdotally, we have 2,200 complaints that we are getting ready to investigate. So we have a whole rollout plan. We will be focusing more of our energy for the next couple of months on complaints versus survey, but we will be touching every nursing home, I suspect, in the next quarter.
Thank you. I did want to say we have a very strong family advocacy group and many groups out there, but 911 Nursing Home is one of the groups that have a lot of members and have really been advocating for change and focus in this area. And one of the recommendations they wanted me to offer to you is that maybe there's a surveyor or an individual that's assigned by region or facility that could be the contact person. And that also could build relationships with constituents between the department and individuals so that they had a contact person. So that was a recommendation that they wanted to put out there.
Okay, excellent suggestion. I will tell you, for the past year, we did change our work stream in that we assigned teams of surveyors to regions, so that when we were conducting our infection control surveys, it was the same surveyor that was going into the building, so that they would note that if there was a change, if things looked different with staffing, if they became very comfortable with the specific nuances of that building and were able to pick up if there were any changes in infection control. So the process was really very valuable this last year. PMS has recommended that we do not assign residents to specific nursing homes because there's a concern that in the big picture, when looking at the 500 pages of regulations, that there could be complacency or desensitization to certain things. So they don't recommend that. But I think this is a recommendation that we can bring to our group at DPH and perhaps morph it a little bit so that at the very least you have a supervisor that may be familiar with a core group of nursing homes and could be a contact person to family members. So I will take that to our group. I think it's an excellent suggestion.
Thank you. And this one came in from Facebook Live the other night. Why, when there's outside visits, are you required to be monitored, causing them to be cut short, canceled, or changes made due to staffing? We were told that there was a DPH life safety surveyor who said that they can't have visits outside without a monitor. There's no heater, no tent. Because I said, well, maybe, one of the team members, if there was a heater or tent, would want someone to be monitoring the area. But they said no heater, no tent, but they have to have a monitor outside if residents are outside having visits.
So the expectation is that outside visits should be monitored as well. And again, monitoring for those core principles of infection control. However, a visit should not be cut short, whether it's an outside visit or an inside visit, because of a staffing issue, or again, canceled because of staffing issues. The facility needs to make every effort to be able to keep this moving so that we can keep families reunited. There may be unique situations where if there was an outbreak with staff, and that may interfere with the staffing monitors. But I think as a matter of course or a matter of routine, the staffing should not be impacting a family's visit. And I'm going to follow up on the life safety surveyor to see what that's about.
And one of the questions that I've seen pop up, we're getting to the Facebook Live questions now, and one of them that I see is related to, and that you and I have talked about this, Barbara, leave of absence, LOA. And one of the comments says, how come residents aren't allowed LOA yet? And I just want to reiterate, residents absolutely are allowed to leave the nursing home. They may leave the nursing home. Actually, the guidance speaks to that and says, if an individual is vaccinated and leaves the nursing home for less than 24 hours, unless they have known contact with someone who is ill, is COVID positive, that they should be able to return to the nursing home, have that assessment done. They're still going to ask you questions, right? That's good practice. They're going to ask questions. Where were you? Who were you with? How was your time? And you should be able to return to your original room. Again, that's for individuals who are vaccinated. For individuals who are not vaccinated, there may be other questions because there may be more risk. And it does say that there could be a higher potential to have to go into observation at being out. I know we talked about if someone had children around that were in daycare and they weren't vaccinated, that might be a risk, right?
So we actually provided 3 vignettes today. We had fun developing these vignettes because they were so similar to real life events. And one of them was a fully vaccinated resident who went out. No, she was partially vaccinated and she went out for her second dose of Moderna. And she was also going to have lunch that day, and she was going to the hairdresser. So we wanted to give the facility different nuances that would cause them to pause and think about what they would need to do when that resident returned to the facility. So because the resident is not fully vaccinated or 2 weeks out post both vaccinations, we gave her a name. I think it was Mrs. Sealander. It was my maiden name. So she went out to lunch, and because she wasn't fully vaccinated, there are some risks and concerns associated with that. But we had another vignette that spoke to, as Mairead has indicated, a fully vaccinated resident who went to, her daughter was resuming a Thursday night dinner that they were doing. She went to her daughter's as she normally did. And again, fully vaccinated. She was with fully vaccinated individuals. And when she's returning to her room, it should be her room and not an observation unit. So I'm hoping that those vignettes were helpful to facilities today. And we'll continue to meet with the providers on Wednesday. We will continue to answer their questions as they come through the chat. But we also, I can tell you, I answer several questions every week about visitation and work with a few facilities every week when there seem to be some gaps or confusion about visitation.
And Barbara, if I'm correct, the vignette with the individual who was vaccinated, the home was in an outbreak.
Yes, yes.
And even if they're in an outbreak, they have the opportunity, the right to leave the nursing home. We're really asking that nursing home team leads talk with the resident, talk with the family member, discuss any risk, and that all that information is given prior to the visit and then followed up after the visit. Why does the number of people in the nursing home matter? So that was part of the guidance that came out from CMS, that the nursing home needs to know how many individuals are there visiting, that they have to be able to maintain physical distancing. And that's part of the parameters that were put in place with the visitation guidance. So that's why you would continue to see that as one of the concerns that needs to be addressed and highlighted.
And it really falls back and focuses on those core principles of infection control with social distancing.
Absolutely.
I'm still seeing when I go into some supermarkets that they're counting.
Mm-hmm.
So it's critically important that we follow those core principles.
Can it be recommended that unvaccinated staff be required to take an antigen test every time they come to work and a PCR test once a week, so that it's not impacting visitation as much when there's someone who has a positive case?
So they're currently getting weekly PCR testing. And I know some facilities are still doing antigen testing intermittent during that week. I don't know if there would be any changes to the visitation because they would still recognize or pick up on the weekly PCR testing if there was a positive. But we can circle back with Vivian, Dr. Leung on that.
Thank you. The nursing homes need to be reminded of these guidelines. We as family members and friends know these by heart. And so I know that's come up a few times, and I want to reiterate that this forum, I know there's some people on here that are very well informed and very connected to the information, but this also is available in the nursing homes for residents. Many residents get on here. They also watch later, and nursing homes log on and bring them the information, where the regional ombudsman are communicating with them and notifying them to watch this. So although some people have all the information, it is important for us to continue to do that outreach for the individuals in the nursing homes that we serve, that also ask us regularly to have this information given to them. There's also a few questions on here, Barbara. There's been a great desire to connect with Commissioner Gifford. And so I know that many of the residents and family members have asked sort of, where is she? They want the ability to connect with her. I have reiterated that she does meet with us regularly. She hears the concerns, and this area, I believe, is very important to her. But I know that her demands are vast in the amount of things that you all cover at DPH. But I didn't know if you could speak to that a little bit, or if you had an opportunity to talk with her.
So as you all know, she is commissioner for two very large agencies, with DSS being a lot larger than DPH. I can tell you in my conversations with her, and as Mairead has indicated, we do have interagency meetings at least once a week. At DPH, she is on a meeting with us at least 5 times a week. And she is hearing visitation and how critically important it is. She was just as excited as you were when the September guidance came. And then when the guidance came on March 10th, I think she was more excited than most when she learned that people could touch. She's a doctor, so she truly understands, and I certainly do not speak for the commissioner, but she truly understands the value of touch. So please know that she is aware, very involved, but managing at this point 2 agencies in the middle of a pandemic. And I suspect that she will be coming to one of your Facebook Lives. I will not be surprised, but she's still a real integral person to the pandemic plan that is still here. I was hoping that it would at least be kind of turning the corner and be in our rearview mirror. And while it's getting there, until vaccine is done, or at least as much is going to be done, I think we won't see it in our rearview mirror until that time. But we continue to see great progress being made. Our numbers in Connecticut are really, really good. And I'm always happy to talk about the Connecticut experience. Visitation is something I get to meet weekly with CMS. And invariably, I would say at least half of our call is focused on visitation. When the revised guidance came out on March 10th, there was a sentence in there that indicated that when there's an outbreak, we had just a couple of days before that, had indicated that outdoor visitation shall not stop under no circumstances. And then the March 10th guidance came out, and there was a sentence in there in the indoor visitation category, but that indicated that if there's an outbreak, all visitation is suspended. And it was like all of our heads popped off, that we were so happy to say that outdoor visitation happens no matter what, and now visitation is suspended. So we reached out to CMS, and they indicated that absolutely not. Outdoor visitation continues regardless of what's happening inside the building. Thou shalt continue the outdoor visitation. So I just reinforce that because these are important issues for Dr. Gifford, and she is tracking the visitation and tracking the essential support person program very closely.
And I will say, I have shared before that even though she has not been able to join us, that she has been very supportive, and I would say was one of the moving forces behind the symposium today, making sure that the information in an accountable way went out to the industry, long-term care industry, that it came from the department, and that they knew it was her expectation that visitation move forward. So I have not felt in any way that she did not support us, or having this happen. Her availability hasn't been there. As Barbara said, she is juggling many things, but has told both myself and our commissioner, Commissioner Porter, that the expectation is that we would have access to the team members at DPH and that we would work together to move something forward. So thank you for that, Barbara. Okay, we're gonna try to take a couple more questions here. My grandmother contracted COVID-19 6 weeks after families were first shut out of nursing homes. What measures has DPH put in place to make sure that this doesn't happen in the future with any viruses, while still avoiding residents' physical, emotional, cognitive decline and the death of failure to thrive from isolation and isolation from family members? Ooh, that's us.
So lots of work has been done to prepare for, and we don't want to think in this fashion, but we have to think about what are we going to do if there's another pandemic or another outbreak. So there has been lots of work that has been done. You may have seen the legislation that is in proposed legislation right now, with lots of expansions to the infection control program. One of them being a full-time infection preventionist. Each facility shall have, regardless of their size, in an outbreak, a full-time infection preventionist in place at the time to monitor and surveil the infection control program. The legislation is, as we mentioned earlier, about the Essential Support Person program. DPH, if the legislation moves forward, and it's, I think, House Bill 1070, requires DPH to develop an Essential Support Person program in the event of another outbreak or incident. So there's been lots of planning. There was a nursing home assisted living oversight work group that had 3 breakout sessions. One was related to infection prevention, one was related to staffing, and Mairead, the third one was focused. The spirit of it was, how do we keep people engaged and how do we meet psychosocial wellness for individuals in a nursing home in an incident or an episode. So there's been lots of work that's been done. Pandemic has provided lots of teachable moments for all of us.
Yes, we have learned a great deal. We have a couple of other questions related to filing a complaint and timelines, and Barbara's going to send me that and we will post that to our website about what to expect and what would those options be, as well as contacting Barbara if you don't or never hear back or didn't hear back. Why not with the same vigor this year? Were complaints and surveys done? And I believe that's because the Department of Public Health was told by CMS, who provides guidance to them, that they weren't able to do surveys at that time or complaint investigations during COVID. Their focus was in infection control and on other things, and so they weren't going into the homes. We know that was challenging, and I'm sure that was challenging for you all, Barbara.
Mm-hmm. And I will send a copy of that memo so that you can share on your website.
Thank you. Does DPH consider a weekly visit for a half hour outdoors with social distancing after fully vaccinated, reuniting families? So I've heard this twice today now, and I do know the individual on here. There are some homes that are still not allowing the choice for touch, or saying you can only hug at the beginning and at the end of the visit, but you're not allowed even outside, and you're fully vaccinated, to choose to have physical touch. And my answer to that is we do want to know, and we are sending those complaints into DPH, but I know with the timeline, because of the backlog, people are concerned that by the time they get to them, it's going to be too late.
So we have a robust plan to get all of our investigations done. I think if we're seeing a trend or a theme, there are ways that the answer is not always submitting a complaint. I have had conversations with family members over the years that when I spoke to them, when they've had a complaint, and again, it always is predicated on the issue. There are certain issues that we need to get out there and do an on-site visit. But there have been other concerns that we have been able to manage with a phone call to the facility with permission from the family member. And we have been able to facilitate those situations so that it's not entered as an investigation. We're always very happy to enter as an investigation, but it goes into, there's a process for that. So if there are situations that you have tried to work with the social worker, tried to work with the administrator, and you're not, and you've reached out to the regional ombudsman. 6 weeks ago, Mairead and I made a call to a nursing home. There was a concern about visitation, and it was a knowledge deficit. And I think together with the conversation that Mairead and I had, I haven't heard that the problem continued, Mairead, but I thought that was a very valuable conversation. And it could have been entered as a complaint with an on-site investigation. And certainly we are happy to do that. But often there's a quicker resolution if starting out with the facility, trying to resolve it at the local level, but also I'm not naive enough to know that sometimes that doesn't work, and often it doesn't work. But if there's a way that we can do that with a phone call, and I'm not asking 100 people to call me tomorrow and say I tried and please make a phone call, but those are situations that we do want to be able to support and assist if we can.
And there's actually a number, and we're not going to get to all of these because we are going to have to go, but there are a lot of concerns about the response, needing to see it as important, the new guidance, and visits happening, you know, showing up and saying, oh, I'm sorry, you're not going to be able to visit today. And just in reading these, Barbara, I'm thinking maybe you and I we will take the comments and look at, is there a way that my team can triage them? And then even if we set up maybe a weekly meeting or some way with permission from residents and family members to look at where are the biggest concerns? How do we partner to respond when we're really realizing there's some there are barriers to people getting quality visitation? Because we know it's happening in some places, and if it's not happening for everyone in a consistent way, maybe between the two programs, agencies, we can develop a way to identify and, again, not waiting for a complaint, but to respond. Maybe it is a call between the supervisor and I to the building, and triaging that in some way so that people don't feel like they're waiting. One facility only Monday through Friday can only visit only compassionate care visits on the weekends. Is this allowed? No, they should absolutely have visits available on the weekend. If they're open for visitation and there's indoor visitation possible, it should be available every day. There needs to be a plan in place. Again, they should be providing you all with their plan. Visits outside or on the patio, 2 people. So I'm going to go through the rest of these and we can try to answer them.
So, Mairead, as I think this through,
a lot more questions.
maybe there is an opportunity here to, you know, this is a message that we are going to continue to deliver on our weekly calls. This was not a one and done today. This was just a focused presentation today to provide some talking points to first remind facilities of their obligation. This isn't a may, this is a shall. So it was our first, and I don't even want to indicate that it was our first. We started this weeks ago during our weekly industry call. It's a message that we're going to continue to deliver. But maybe we can, maybe every week, we can think of a specific situation that has come up that week. I'm thinking, as you mentioned, the policies and plans. I wonder how much nursing homes are sharing their plan with family members.
They're not. We're consistently hearing that it's a facility document and they're not sharing it. That's why I focused on that today. Right. And the fear of retaliation is coming up in here too. And so for individuals, just so you know, when you all tell me things and you say, please don't give my name. When I talk to DPH, Barbara will tell you, I think sometimes it's almost frustrating because we don't give your name. We could talk about scenarios. If you don't even want us to give the building, we don't do that. The regional ombudsman might drop by the building and ask questions about visitation. How is it happening? When it's happening? Ask to see the list. So we do have ways to go about trying to resolve the issue without highlighting a person or who brought it to our attention, because we acknowledge that fear of retaliation is real. We want to support you all in your ability to feel safe and have those complaints addressed. And when you ask us not to use your name, we do not. But we do send over scenarios. I sent one today about issues and concerns that have come up related to investigations, things. So when you do ask us, we do make sure that those messages get through. I'm going to go through here. Maybe Dan and I can do it together because there's so many, or a few of the ROs. There are literally hundreds and hundreds of messages here, Barbara. So we clearly have a lot more. And
this is an important issue for us, though.
It is. And so we want to address these questions. And we can get more answers and be back and connected with you all to give them. But I really appreciate everyone coming on. People have been, I think, very willing to express their concerns and work with us and help us try to resolve these issues. And I want to thank you, Barbara, for coming on, taking these questions, for working with the homes, and for always being there when we call to say that there is an issue and trying to help us resolve it. So thank you very much.
You're welcome.
And thanks, Dan, for helping us behind the scenes always.
Thank
All
you
right.
all. Stay well.
Good night. We'll talk to you soon.